Epidemiology of Periodontal Disease. I am Pulikotal Shah Jacob, Associate Professor in School of Dentistry. So these are the contents, and let's proceed to the class. So what are our learning objectives? At the end of this lecture, the students will be able to explain the epidemiology of periodontal disease and also explain the relationship between gingivitis and periodontitis. Let's get on to the definition. Epidemiology is the study of health and disease in populations and how these studies are influenced by hereditary, biology, physical environment, and personal behavior. Epidemiologists also observe diseases and conditions in populations, and they also help identify the patterns to explain the occurrence for our better oral health. What are the aims of epidemiology? They are to describe the size and distribution of disease problems in human populations, to provide the data essential for planning, implementation, and evaluation of health services for the prevention, control, and treatment of periodontal diseases, for setting up of priorities among these services, to identify etiological factors in the pathogenesis of the diseases. Let's have a small quiz on this. Right? You'll be prompted to click an article and the questions will be related from the article. The case definitions for the diagnosis of periodontal disease. Case definitions are methods used to diagnose periodontal disease or periodontitis. They can be classified as three types: immunological and biological tests to measure the individual's response to periodontal pathogens are still being in the developmental stage. Because periodontal disease is a chronic infectious disease, microbiological tests have been developed to detect the presence of specific periodontal pathogens in the gingival sulcus or pockets and hence can form the basis for the diagnosis of disease. The third one, or the most established one, is the assimilation of clinical and radiographic information such as bleeding on probing, pocket depth, attachment loss, and bone loss in the diagnosis of periodontal diseases. These tests are useful for planning treatment for the new patients, selecting appropriate recall intervals, monitoring periodontal therapy, determining appropriate antibiotic therapy for patients who do not respond to conventional therapy, and also for screening patients before extensive restorative or implant therapy, apart from also measuring the level of disease in the population or community. Now let's have a small quiz related to this area. Another important aspect of epidemiology is to identify ways to reduce the presence and burden of periodontal disease. Risk factors estimation and its influence in periodontitis is very important and it can vary in different populations. Now towards a small quiz as you go through this area of the risk factors, risk determinants, risk indicators and risk markers. The risk factors will be dealt with in another lecture in this course. Let's discuss on the epidemiology of periodontal diseases, which includes primarily gingivitis and periodontitis. We will discuss how much of disease is present in a few populations. But before we start, why do we need to know about this? Will it help us in our dental practice or to help a patient with periodontitis? Let's get on and see if we can answer the above questions. What was the belief in 1960 on periodontal diseases? It was as thus. All individuals were considered more or less equally susceptible to severe periodontitis, or else it means that anyone can get severe periodontitis. Second, gingivitis usually progressed to periodontitis with consequent loss of bony support and eventually loss of teeth. So again, everyone could have the possibility of losing teeth. Third, susceptibility to periodontitis increased with age and was the main cause of periodontal or tooth loss after the age of 35. So after 35, you are very likely to lose teeth. So this was the belief in 1960s. So all these questions, all these observations led to few questions in us. So the two important questions was asked in epidemiology of periodontal disease were, what are the levels of disease in the population? It is important to know the amount of disease for policymakers to determine the healthcare resources needed to alleviate the burden due to the disease in the population. If the morbidity is less, as well as the long-term effects are not so great, then will more resources be allocated? No. So what do you think would be the allocation for periodontal disease? The other important question is, what are the major risk determinants of its extent and severity? Identification of risk factors is prerequisite for the development of a successful intervention strategy that may be used to control the disease on the population level. So, if you know a risk factor which is causing the periodontal disease or helping to progress the periodontal disease, and you intervene it or you modify it or you reduce it, then the amount of periodontal disease also will reduce. Let's see the prevalence of gingivitis and its distribution. In the first US National Survey of Adults in 1960 to 1962, gingivitis was scored visually, or rather, it was seen and scored whether a person had gingivitis or not. It was found that 85% of men and 79% of women were found to have some level of gingivitis. In the National Survey of Employed Adults in 1985 to 86, 47% of males and 39% of females aged 18 to 64 exhibited at least one site which bled on probing, which the bleeding on probing was considered to be gingivitis. Did you notice that there is a difference in the level of prevalence? Whereas in the third National Health Survey, NANS 3 1988 to 1994, 50% of adults were found to have gingivitis on at least 3 or 4 teeth. About plaque and gingivitis. Plaque deposits are closely related with gingivitis, a relationship long considered as one of cause and effect. Longitudinal studies observe recruited patients on the development and prevalence of gingivitis or the disease for a long period of time to ascertain if there are risk factors or any cause which can influence. In a study among Norwegian professionals and students who had excellent oral health, there was no increase in prevalence and severity of gingivitis between the late teen years and age 40. In a related study on Sri Lankan tea workers, they were observed on the effect of plaque and gingivitis. Sri Lankan workers had poor oral health and no access to health care. It was observed that both oral hygiene and the gingival condition were poorer at all ages. Continuing towards plaque as a cause. A study called experimental gingivitis was conducted by Lowe and colleagues. The study evaluated the effect of accumulated plaque by refinement of oral hygiene measures. It was observed that the level of gingivitis was consistent with the level of plaque and resolved once good oral hygiene measures were reinstituted. This study helped to establish that the infectious etiology of gingival inflammation by demonstrating that plaque accumulation is parallel by the development of gingivitis. In addition, gingivitis is a fully reversible condition and thus can provide a rationale for the development of population-based preventive and therapeutic strategies in the form of controlling plaque. Gingivitis and periodontitis according to the Tanzania study. In a study carried out in Africa, Balaam and co-workers described cross-sectional findings on dental plaque, calculus, gingivitis, loss of attachment, periodontal pockets, and tooth loss in a sample of 30 to 69-year-old people. Despite highly prevalent plaque and calculus, pockets deeper than 3 millimeters, and attachment loss exceeding 6 millimeters occurred at less than 10% of the tooth surfaces. 75% of the tooth sites with attachment loss of more than 6 mm were found in only 31 of the subjects, indicating that advanced periodontal disease was not readily correlated to supragingival plaque levels. In another study called the Lowe's longitudinal study, Lowe and workers published data from a longitudinal study which showed that the progression of untreated periodontitis shared similar features. Drawn from a population never exposed to any preventive or therapeutic intervention related to oral hygiene, in Sri Lanka, a cohort of about 480 14 to 31-year-old male tea workers were initially recruited in 1970 and they underwent subsequent follow-up examinations. Despite poor plaque control and virtually ubiquitous gingival inflammation in the entire sample, three distinct patterns of progression of periodontal tissue loss were observed over the follow-up period. One group, comprising approximately 8% of the total, had rapid progressive periodontal breakdown, which is called as rapid periodontitis. Another group, approximately 11%, they exhibited no progression at all beyond gingivitis. And the third group were between these two extremes, approximately 81% with moderate progression only. A clear message emerged from the above studies. Despite the infectious etiology of the gingival lesion, plaque do not account for the majority of the destructive periodontitis encountered in the population, which in turn indicates that other exposures, either environmental or host related, must have a decisive impact on the development of the severe periodontitis phenotype. Or rather, in simple words, can we say that there is only a small percentage of people who can get severe periodontitis. And also another one important evidence is on the anvil is the host response and host susceptibility, which states that the host or the person who is bound to get periodontitis is the primary determinant for the occurrence of periodontal disease. These are the references, and the other references you can see in the video with a highlighted one which you can click and get onto the references. Thank you.